Okay, this lecture is just on part of Chapter 28 on sexual health. This little tidbit here will just be on infections. Okay, so let's talk about bacterial vaginosis. In the female client, the normal pH of vaginal fluids are 3.8 to 4.2, and typically for bacterial vaginosis, the pH goes higher than 5.0. It is the most common infection, is known by its white-gray discharge, and its characteristic is immediately recognizable as a fishy amine odor. The treatment for bacterial vaginosis is flagyl or metronidazole. The most important thing about when we give clients flagyl is to remind them that they should have no alcohol for 24 hours before or after taking that medication due to the amount of severe nausea and vomiting it will give them. Another thing is that we don't typically give flagyl during the first trimester or when moms are breastfeeding. One of the most common infections is a fungal infection known as a yeast infection. The pH is typically 4.5. Women report vulva itching and redness and thick white discharge. Typically, the first recommendation is over-the-counter creams such as Monistat, which is miconazole, or gyne-lotrimin, which is clotrimazole. For some, one product works better than the other, and typically it comes anywhere from a 1-day to a 7-day treatment pack. If that does not resolve the yeast infection, or if they have frequent yeast infections, they may be given a prescription for diflucan, which is fluconazole, which is an oral medication. And what is important to know about that is that it is not always recommended when people are on something like a antidepressant like citalopram or Lexapro. And the other thing to keep in mind is when people are using the over-the-counter creams, those are oil-based and they do render latex ineffective, and so they should not be having sex if condoms are the only form of birth control they are using. Trichomoniasis is also another common infection in the female genitourinary tract. It is caused by a protozoa. It oftentimes causes what we call gray-green or grayish colored discharge. Sometimes it's tinged yellow as well. Oftentimes people will notice ulcerations of the vagina or of the cervix, and it has a higher pH, meaning it's an alkaline infection, and it is oftentimes as well treated with metronidazole or flagyl. And it is very important with trichomoniasis, since it's a protozoan, that both partners are treated simultaneously. It used to be that the second partner had to come in for a prescription. Now, if one partner has it, the provider can write a prescription for both partners without having to see the other partner. The other important thing along with that is with flagyl, always recommend no alcohol 24 hours prior or 24 hours after treatment due to the severe effects of nausea and vomiting. So the table 28.1 is a fantastic table in your book. It is easy to refer back to anytime that you're trying to rule out or figure out which one is happening. And so this gives you just a good difference between the symptoms, the exam findings, the pH, and just puts it into a good, easily read table format. Chlamydia. It's the leading cause of infertility and ectopic pregnancies due to the amount of scar tissue that it creates inside the fallopian tubes. What's concerning about chlamydia is that 75% of female clients are asymptomatic with chlamydia. They recommend screening annually for under age 25 for anyone that is having either reporting multiple partners or is sexually active and has a partner change. The treatment for chlamydia is Zithromax, doxycycline, erythromycin or Levaquin. And as same as some of the other STIs, the sex partners should be treated. Gonorrhea is the second most common STD, and for male patients, it will create typically dysuria and discharge, and they're fairly symptomatic with it. For most women, they can commonly be asymptomatic infections of gonorrhea. So when we find it, we treat it with Rocephin, Zithromax, or doxycycline, and again, the sex partners should be treated. Do be aware that because of its insidious nature, it can cause pelvic inflammatory disease that can also contribute to decrease fertility, and that people can also get gonorrhea in their throat and in the rectal area, so they can have pharyngeal and rectal gonorrhea and chlamydia. Syphilis has been making a comeback, meaning that it is more prevalent in the world now than it has been over the last several decades. Their typically first presentation is a painless chancre about 10 to 90 days after exposure, and oftentimes they don't seek help at that point unless they come in for some other sort of viral illness, which they think it's some other viral illness. It lasts about 4 to 6 weeks, and they have typically lymphadenopathy, so they've got some swollen lymph glands and some discomfort in those lymph glands, and it might be more typically not your lymph glands that are in your armpits or in your throat. It may be groin, it may be some other areas. So atypical lymphadenopathy for a viral type of infection. Secondary syphilis starts at 6 weeks to 6 months after that painless chancre. It resolves after 2 to 10 weeks, and again, it presents very much like a viral infection: fever, sore throat, a rash, a headache. They're very vague symptoms that people present with, and oftentimes we don't necessarily notice that they have syphilis unless we are looking for testing that by either report or suspicion after maybe they had come in for a painless chancre before or had reported one as being something that bothered them a few weeks ago. Then if it's not resolved in secondary syphilis with some antibiotics, then it becomes tertiary syphilis, meaning it goes dormant in the body, appears anywhere from 1 to 10 years later, and is considered neurosyphilis at that point. Can cause some very varied neurosymptoms that can include delusions. At any stage, the treatment for syphilis is the same. It is penicillin or another antibiotic utilized to suppress the infection. Toxic shock syndrome, I don't know that it is in your book. However, it is fairly common, and we do see it sometimes in the emergency room primarily. It is when bacteria such as Staph aureus or Strep pyogenes crosses over and into the bloodstream, and they become septic. Oftentimes patients present with a fever of about 102, a diffuse red rash, vomiting, diarrhea, and malaise. We treat it with antibiotics. Sometimes in the report that a client will give you will be that they maybe left a pad on for a day or two, or they left a tampon in, and that would be possibly the source of that staph or strep growth. Pelvic inflammatory disease is an ascending vaginal infection. It targets the uterus and the fallopian tubes and goes up into the ovaries. It oftentimes presents as pelvic pain or occasionally purulent cervical discharge. If not treated, pelvic inflammatory disease can be very serious. It can cause scarring, it can cause adhesions and blockage of the fallopian tubes, affecting fertility, tubal pregnancies, increasing those risks. Sometimes people are not symptomatic, so it is important that if they have frequent infections such as chlamydia or gonorrhea, that we're also assessing for this pelvic inflammatory disease. If they have an active inflammatory infection, they're going to have fever, chills, abdominal pain and tenderness, abnormal bleeding. And then we have what's called the cervical tenderness, which is called chandelier sign, meaning that when a provider goes in with a speculum, if they touch the cervix and move it side to side, anytime they move it, it makes the patient incredibly discomforted, like it makes it much worse. That's called the chandelier sign. It is important to treat this as soon as it is noted and to encourage people with any sort of abdominal pain, tenderness, fever, bleeding, that sort of thing to get attention, simply because we know the longer that infection goes on insidiously, the more chances of scarring and issues with infertility. So treatment with PID is typically 2 to 3 antibiotics. You can have ceftriaxone, you can have doxycycline on top of that, you may have metronidazole. There may be just all sorts of things that we kind of attack it with. And then sometimes if we don't have any response to those medications on occasion, and it's fairly rare, but there are times when people have to be hospitalized for some IV antibiotics like clindamycin and cefoxitin. So herpes simplex virus is actually 2 different viruses when we think about it. It's HSV1 and HSV2. Both cause kind of a similar reaction. It's just thought to know as where it is. So most people are carriers of either one or both of the viruses, and some people who carry the virus will never have any symptoms at all. So HSV is the most commonly associated with oral cold sores. They are thought to be, quote, quote, the good herpes, not that they're it should be any distinction. HSV2 is most commonly associated with genital lesions. Those are more likely to cause frequent outbreaks during viral shedding. So anytime someone has an immune reaction to a virus, they may have more infectious breakouts. And then as they have the cold sores or as they have the lesions, those shed viral components, and so that is why they are highly contagious. So important components about the contagious status of HSV is that there are periods of silent viral shedding where the virus may be present in the mucosa but no lesion appears. And then individuals are also contagious just prior to, during, and just after an outbreak of HSV. And typically HSV is also known as a painful vesicular rash, with some erosions and blistering appearing. It looks like it typically will ooze for a little while as well. Oftentimes it's a recurrent infection, and our treatment isn't really a cure. It's really just that we try to eliminate active infections. So in suppressing the virus, to prevent outbreaks, reduce viral shedding, shorten the length of time of an outbreak, we typically use about 3 medications. So we use valacyclovir, acyclovir, and famciclovir, which are fairly similar, all slightly just a little bit different in makeup, but typically need to be dosed oftentimes before, certainly to suppress an infection, especially during pregnancy, or when an outbreak is noted, and then for some time afterwards. So some patients will have that continual suppressive therapy. Others will just know when they feel signs and symptoms that they take medication, and it just kind of it varies from client to client as to if they're on one of these medications fairly often or if they are on it just periodically. Of note is that the HSV virus can also have an outbreak in the eyes and the lung nerves. People can have eye surgeries where then we place them on an HSV suppressant to avoid having any flare-up during eye surgery. The other thing to think about is transfer to a fetus during pregnancy, and so it can be during a delivery. We may oftentimes, if they have any active outbreak or recent active outbreak, they may become a candidate for cesarean delivery instead of a vaginal delivery. Okay, so HPV, or human papillomavirus, is skin-to-skin transmission. It is important for parents to understand that it is skin-to-skin transmission, that youth do not have to have intercourse in order to contract HPV. It's important for LGBTQ populations to know that this is a skin-to-skin contact, and that even if they're not having intercourse, that they can pass on the HPV or contract it. HPV vaccines are available. There are about 50, I believe, strands of HPV. There are several, especially 16 and 18, that are the most virulent and the most likely to cause like cervical cancer. And so it is important to stress that HPV vaccines can be very helpful in reducing people's chances of having preterm delivery from cervical cancer treatments. You'll notice in your book that you have quite a few other diseases or infections that are listed, such as hepatitis, HIV, but I know that you guys cover that fairly well in other classes, so if you have any questions about that content, do let me know, and we can review that in class. Otherwise, this is the end of your sexual health infections lecture. Thank you.